Hey, I'm Mason with Live Oak Testosterone and Weight Loss. I'm here with Addison. She is the nurse practitioner that handles the medical dermatology and the aesthetic side of Live Oak Testosterone. Can you tell us a little bit about yourself and your background?
Sure. I've been a nurse practitioner for 10 years, I guess 8 or 9 years, and predominantly in dermatology and cosmetics in Florida, and then came here to Texas about 6 months ago and have been kind of introduction into the hormone weight loss side of things.
Dermatology is kind of a mystery overall to me from my background in the ER and urgent care. I feel like I just know the surface, scratching the surface of it, and I can, of course, look up to date for the first thing, and then I can prescribe that, and then after that, I have no idea how to troubleshoot or what is next or anything. So a few of these topics, I'll have some of my own questions as we'll be going through. But I think let's first just start with acne. I feel like that is probably the most common thing that I have seen on your schedule to be managed. And even whenever I'm looking to see an acne patient, if they came to me, I would look up to date, and it would maybe say 4% benzoyl peroxide, and I would try that and put a referral into derm and hope I'm not following up with them.
Yeah.
What is your approach to seeing an acne patient, and what are you looking for? What are the different types, if that would make any difference from your management, and what can they expect with your treatment and treatment recommendations?
Yeah. So first, I'm going to initiate and assess the patient and a couple of different things. Genetically, ethnicity-wise, what age are they? Was this a sudden onset or has it been something long-term? And the type of acne is going to be what gears my approach of treatment. So with acne, you have a few different types. Comedonal is going to be open and closed blackheads, whiteheads, and then which would be a more mild. You can have a mild variation of that covering face. You can have a severe covering head to toe. Worsening of that would be when you have more papular, pustular acne, which is going to be more pustules, more inflammatory bumps. And then a more severe variation of that is going to be when you have cysts and nodules that are going to be much deeper under the skin, and sometimes in combination with comedonal acne. So the type that they have, the age that they are, and where it's located is what's going to gear my treatment. That being said, there is not always a quick fix to this, and this is the difficult part about treating acne patients. It's typically going to be a lifelong journey. A lot of the time, we're seeing young kids that are 15 and 16, and yes, most of the time they kind of grow out of that by their 20s, but sometimes genetically, our oil production and our pores just predispose us to acne lifelong. That being said, you can also have the deeper, more pustular, inflammatory type of acne that is hormonal and that does kind of pop up later in life. And so that's a little bit of a different entity in how we treat that. But starting on a basic level, you are definitely going to have your benzoyl peroxide, and that's typically a go-to because it is typically tolerated pretty well. Benzoyl peroxide is going to work on decreasing the bacteria that is caused by acne, and it helps to oxygenate the skin. Sometimes that can be at fault, though, and that can sometimes worsen acne initially. It can cause some redness and some burning, sometimes to a severe level where they cannot tolerate it. So we reserve the higher strengths. You have 4% and 10% typically. 4% is going to be more for the face. 10% is pretty harsh, and some people do use that on their face if they can tolerate, but that's going to be more for body acne. In addition to benzoyl peroxide, topical antibiotics like clindamycin and azelaic acid are also used for acne. But what these are doing are, again, targeting the bacteria that's causing acne. They're not preventing acne. When it comes to preventing, we then move into the retinoids. So the combination of benzoyl peroxide and antibiotics can be very helpful. But we also want to prevent their acne. We don't technically want them to be on this stuff forever, but retinoids or retinols are going to be what I would call our workhorse for acne. These are the medications that open our pores, clear them out, and prevent them from refilling. So this is what's going to treat their acne and prevent their acne, which is what anyone with acne wants. So These are the medications that create a peeling and purging process. So it makes your skin over a 27-day time frame start to peel. And in the peeling process, it's slowly pulling everything out of the pores, which is when you get a purging, which is when all the stuff in your pores is starting to slowly come out. And then the goal is to keep using it to where it prevents it from refilling. So these range in strength from very, very low strengths over-the-counter adapalene to middle grade strengths like tretinoin to higher strengths like Tazorac, and then even oral retinoids like isotretinoin or Accutane. So that obviously is going to range based on their severity. Obviously, somebody with cystic nodular acne is going to need a Tazorac or an isotretinoin. Somebody with mild comedonal acne is going to need adapalene or a low-dose tretinoin. But the big thing about acne that I think is difficult in the beginning of treating it is what I call the suck it up phase. When you first start this routine, you're going to experience a variation of redness, burning, stinging, peeling. And people think, I can't tolerate this, my skin is too dry. But really, it's exactly what the medication is doing. It's creating this shedding or this peeling process. And the only way to get past that is to continue using it. So people have trouble controlling their acne because they start and stop, or they're only using their retinoid a couple times a week. So they peel for a few days and then they stop. And I have to kind of educate how the medications work so that they know, okay, this is supposed to happen. I need to stick with this. And then the peeling stops. And that's when they're in that continuous state of creating skin faster. And that's how we treat the acne. During that phase, which is anywhere between 1 to 3 months of starting a skincare routine, we usually couple the rest of the routine with being very gentle. So gentle cleansers, gentle moisturizers. We don't want harsh acids or too much exfoliation. The routine is typically very gentle while we're getting used to medications, 2 to 3 months. Then once they're used to that and they're not peeling or red or burning anymore, then we can reintroduce other beneficial ingredients like acids, like salicylic acid and glycolic acid. But the beginning is crucial because this is when your skin is remodeling or readapting to what the new treatment plan is going to be. But if you don't do that right and you stop, or you add in your own things, you could make your side effects a lot worse. You can really worsen peeling and burning. You can cause blisters and scarring and infection even if you're not doing it, as advised. So sticking to that regimen and that routine is really important for the beginning part of that acne treatment. And then following up is going to be key. We usually follow up every 3 months because it can take 2 to 3 months to get the full effects of the strength of the medication and how it's working. So if you come back to me in 2 weeks and say this isn't working, I can't assess that was really a failure in treatment because it was not technically long enough for the meds to have worked. We typically see them every 3 months and reassess how they're using it, if they're using it regularly. And a lot of the patients are honest and they say, I'm using this once a week. And I have to be, straightforward and say, that's not how this is indicated and you're not going to get effects from using it that way. So I think that's a big part of starting with the acne and getting people on the appropriate routine. Typically, after 3 to 4 months, you kind of know what's working and what's not. If I have somebody that comes to me and they're on a pretty good routine and they're doing it religiously and their acne is still not really well controlled, then I kind of look at my alternatives of what else do we need to go up in their retinoid strength, or do we need to add something else? When we have inflammatory pustules and nodules and cysts is when I sometimes couple in oral antibiotics like doxycycline, because not just for bacteria purposes, but for inflammation. So doxycycline works really well on the inflammation that's causing the nodules and cysts in addition to the topical routine. So that would be what I call like putting the fire out. It's not going to be something they're on long term for years, but it is what's going to kind of put that fire out while their topical routine is starting to work.
And you don't want to be picking, or if you have them, pop them, Because I've never done that.
Correct.
No,
So that's a big thing that I tell everybody. Things to avoid with acne is going to be picking and popping, and we've all done it, and it's really hard not to be honest. But picking and popping actually contributes to acne. Let's say you have one pimple and you pop it. That bacteria and that stuff goes into the skin around it. You may have 5 pimples the next 2 days. So you're literally multiplying the amount of bumps. And if you don't get it out, sometimes it goes down into the skin and then it causes an inflammatory bump where it may have just resolved in a couple of days. So big things to avoid. You want to avoid touching your face at all costs. There's just no need to touch unless you're doing your skincare routine. Avoid picking. Picking or popping can lead to worsening acne, hyperpigmentation where you have a darkening there, scarring that can be very difficult to treat after the fact. You also want to avoid devices. You don't need a washcloth, a loofah, a spinny brush. You don't need any devices when you're washing your face. You can use just your hands and your product. Changing your pillowcase. You want to avoid stopping and starting skincare products. Trying something for a week and then trying something a week later because that didn't work is just not how the skin works. It takes consistency and time for skincare products to actually work. So that's a big thing to avoid. When it comes to dietary restrictions with acne, there's not a ton of research to prove that there are lots of things that contribute. A lot of people think it's all sugar, and yes, sugar can be a small component, but main things that there are science behind is going to be some sugars, some whey proteins like animal proteins, and some milk, some dairy products. So I found that, I was drinking a whey protein shake every day, 2 to 3 times a day. And when I stopped that, my acne got better. And also, there's other things that can help acne aside from prescriptions. Microneedling helped my acne immensely, almost more than certain skincare products did. Chemical peels, microneedling, sometimes even lasers, certain things like that can really help with acne as well.
From a hormonal standpoint, for women, I've seen birth control and then also spironolactone. Mm-hmm. When do you bring in any of those, and does it fluctuate with their cycle? Do you cycle them at all, or do you just keep them?
So I would say I start to think about that. One, if they're resistant to treatment, where nothing we're doing is really working, or their acne really flares. Sometimes it's not on their menstrual cycle. Sometimes it's before and sometimes it's after. But if they really seem to flare in any of those phases, or let's say that they're never had acne, they're 40s or 50s, and they've got this new onset adult acne, is when I'm going to start thinking hormonally. And so spironolactone, anywhere between 50 to 200 is going to be a great approach to that. There's even topical spironolactone. Winlevi is a topical, same concept of addressing the androgens that are the underlying cause of the hormonal acne. So Winlevi is great. It helps work on sebum and the androgens. That's a topical as well. Those are going to kind of be the biggest approach. I don't typically prescribe birth controls, but there are a couple of FDA-approved low-dose birth controls that are secondarily approved for acne. I just don't, it's typically not my go-to, but they're prescribed by OBGYNs and they have the FDA indication. Spironolactone, I think, is the one I use the most systemically if they can tolerate it. Obviously it can affect your potassium, it can affect your blood pressure. I had a teenager that was started on it by somebody else, and she was 16 and she was in cross country, and it made her so short of breath that she couldn't compete any longer. And so that's something to think about as well, of this, what the actual medication is. You have to think about that as well. Or if they're older and they're on blood pressure meds, we have to kind of use it in caution. But that's why sometimes the topicals are a little less risky. The Winlevi, in my opinion, has almost no possible side effects, and it targets the same benefits. So that's kind of where I go for the hormonal side of things.
And then acne can be a side effect on the guys on testosterone. Yeah. And so sometimes we'll change dose or frequency, or maybe try a cream instead of injections, because sometimes it's sensitivity to the carrier oil. Mm-hmm. Sometimes we'll change oils. Where do you think you would go from there on initial treatment in terms of when do we need to add something prescription-wise?
So I probably would do 2 things. One, obviously, like you said, changing, when we switch to the other oil, it really helped. So changing that if that has not already been done for the testosterone. One, the benzoyl peroxide can be great because it's going to work on the bacteria. And when you're treating a large surface area, it's much harder to make a complex acne routine, especially for somebody who lives alone or a guy who can't reach their back. If there's nobody around to help put on products, sometimes I will go the systemic route like doxycycline, where I can do, anywhere between 50 to 100 milligrams once or twice a day, just to kind of put that fire out. Sometimes if you treat them for that bacteria, it is typically not an ongoing, reoccurring process. It's almost like it flares, you treat it, and it somewhat subsides. If that's the case, then a course of antibiotics that's a little bit longer, sometimes a month or two, of doxycycline can be really helpful. They don't have to touch their back. They don't need help to put something on. It's a pill they would take once or twice a day. That can be really helpful. If a wash is also very helpful, typically they're going to wash their body. And if they wash and it kind of washes down that area, they're still going to get the benefit of that. So a 10% benzoyl peroxide wash is always really helpful. Sometimes just as prevention for acne, before and after, it can also help with body odor. So there's nothing wrong with a good 10% benzoyl peroxide wash. So that would be one thing. If they have somebody at home that's able to help put something on their back, benzoyl is really nice, which is a combination of benzoyl peroxide and clindamycin, which is one working on antibacterial production. The other one is an antibiotic. And so there's a cream that you can have somebody, if they have somebody to help put it on their back, or wipes. We carry Zeo wipes that have a couple of different types of witch hazel, salicylic acid, a bunch of different acids in it. If they have somebody that can help them use that, that's great for treatment and prevention. So it kind of just depends on their compliance and their assistance, but a wash and a systemic treatment course are typically what I would start with, because I don't feel, and even from the research I've read recently about what causes the acne when you're on testosterone, it is typically a surge in the production of staph. So when they talk about treatment from it, they talk about just treating that staph infection, and that it shouldn't be like a continuous thing. Yeah, treating body acne is difficult if there's no one to help them put it on there, because that's part of the big percentage in getting success is application consistency, and most men can't reach their whole back. So yeah.
Switch to a different topic, rosacea. What is rosacea?
Yes.
How do I know that it's rosacea, from a medical provider? How would I assess for it? And what would I start treatment-wise, and then also kind of follow-up evaluation if I'm doing it right?
So acne and rosacea have a little bit of a link, but they're different. So when you see acne, again, you're going to see these open or closed comedones or just red inflammatory bumps. Rosacea can also present as red inflammatory bumps, except the difference is rosacea is going to have this underlying background erythema or redness. Acne typically is not. There are 4 types of rosacea. One is going to be just strict inflammatory acne, which presents as little red bumps. Then you can have telangiectasia, which is the fancy term for those really fine red vessels that you can see. You can literally see them. The scattering of that gives that background redness. Then you can have rhinophyma, which is that nodular, misshapen looking nose like this. And so this is the 3rd type of rosacea. And so this happens as a side effect of that constant inflammation within the skin. It's literally remodeling itself and deforming. It's a side effect of untreated rosacea.
Can that be reversed with treatment?
It can, with serious lasers. So that is the only thing that is going to treat that severity of that type, which is very rare. It's typically in middle-aged white men. It doesn't typically happen unless you have a really bad rosacea that is untreated. Like this will eventually turn into that.
How can I differentiate from like an alcoholic nose?
There isn't one. That's
Okay.
typically because alcohol is one of the big triggers in rosacea. So rosacea is chronic and it's inflammatory. There is no curing it, which is one of the most frustrating things about it, because these people have to be on lifelong treatment and they have to avoid the triggers. And most of the things that are the triggers are things in everyone's daily life. So alcohol is a big one. Anything that's going to dilate those vessels. It dilates big vessels, it dilates little vessels. So alcohol, chocolate, caffeine, hot food, spicy food, the sun, Those are like the big kickers. So if you're at the beach, you don't have sunscreen on and you have a drink, that's why you're going to get red. That's why people have that flushing. So people get that because it's alcoholics. There's lots of alcohol in a continuous period of time. They're always red. So there is no differentiating that. That's just their rosacea flaring.
Okay.
So the other type of rosacea is ocular. And so this is where it gets a little bit systemic, where you can have somebody that has something seemingly harmless, but you can have red, gritty, dry eyes. Sometimes you'll have a rosacea patient that says, my eyes are so dry, it feels like there's sand in my eyes. That is the vessels in their eyes that are inflamed, causing ocular rosacea. That is treated with doxycycline as well. So sometimes an ophthalmologist can do it, but typically in dermatology, we're the ones that manage that as well.
Lifelong doxy?
No, typically it's an ocular flare where they would just be on a short course of it. But doxy we use a lot in rosacea because of the anti-inflammatory effects. So doxycycline 20 milligrams to 50 is low dose doxy, and they can stay on that long term. And a lot of the times they are. They're on it for months and months and months, if not years. If they have large red inflammatory bumps, they're really red, or they have ocular, they're going to automatically be on doxycycline. If it's a little bit more mild, we typically would start out with, again, some of the same antibiotic medications, metronidazole, azelaic acid. These are topical antibacterial medications that we use in rosacea a lot. You can also use anything that is going to shrink the vessel. So there's a couple different medications. And honestly, with rosacea, it's so difficult. I, what we call, throw the whole sink at it. And I use compounded medications that have 5 or 6 different ingredients in them to help with rosacea. Shrink the vessels, help with the inflammation, help with the redness and stinging, and just kind of not trial and error because it's so frustrating to them. Insurance looks at rosacea as something cosmetic, and it's not. It can be very painful. It can make your skin very sensitive. It can be embarrassing. It can cause pain. And then it can cause, like I showed you before, the deformities. You can affect your eyes. It's more medical, but insurance hasn't caught up with covering it yet. They're stuck on metronidazole that's the ancient medication that's been used for years, and it's not typically super effective. With rosacea, you can have something called Demodex, and this is teeny tiny little mites, like microscopic mites that actually get into your skin and your hair follicle and your pore and cause this rosacea. So a lot of the time with rosacea, we use parasitics like ivermectin. That is one of, like, Soolantra is the brand name, but ivermectin is one of the main medications that I feel is one of the most effective for treating rosacea. So it can be a little bit of a rabbit hole, and there are different variations, but your average person sunscreen is going to be huge because the sun's one of the main triggers. So sun avoidance sunscreen is massive. Being very gentle because their skin is like almost raw. It feels raw to them sometimes. So not being too strict or harsh with acids or exfoliants, being somewhat gentle, being consistent with medications, avoiding triggers to the best of their abilities. And then lasers. Lasers can be really helpful. PDL, pulse dye light lasers, zap the little vessels, the little telangiectasias, and that can make them go away. So a couple treatments of that is one of the only ways to get rosacea to go away. Yes, they will develop more, and yes, it will just kind of reflare, but it's one of the surefire ways of being really aggressive. Let's say you had a woman and she was mortified by how it looks. She wanted to be super aggressive. I would say an antibiotic, obviously the topicals, and then laser treatments. And it can be something they do, every month, every couple of months. But that's going to be the best way of approaching it. Again, we use a great compounding pharmacy that has a couple of, and it's been over the last 8 years of my experience what I have always used, because what insurance wants to cover is typically not the most effective, unfortunately. So I use a couple of different ingredients, azelaic acid being one of them. This is called triple rosacea cream. So this is azelaic acid, the metronidazole, and that's what insurance wants to cover. I feel like 90% of people get no improvement from it. But if you go through insurance, you have to fail that first before they'll consider covering anything else. And to me, it's just not worth it. So I use compounding pharmacies, and I put 4 to 5 different ingredients in one. And then this also has the ivermectin. And then there's another one, Mirvaso or oxymetazoline. This is the ingredient where you put it on there and you get 12 hours of vasoconstriction. So obviously you put this on in the morning and it literally shrinks up those vessels and like massively reduces your appearance of redness. Is this going to cure your rosacea? No, but especially for women, that's going to reduce that red appearance. So I typically do the oxymetazoline, which is Rofade, in combination with these as well. So I'll add it into that. So they're getting 4 ingredients to help the rosacea because I don't want them to have to trial and error 4 months of meds to find what actually works for them, especially because it's going to be continuous. Some sulfa can be really helpful as well. Sulfacetamide cleansers work on sebum production, and sebum production is sometimes a trigger of worsening acne. So when you can control that sebum, it sometimes helps with that. So sometimes I'll give them the sulfa wash as their cleanser with their combination medication, and then maybe a course of Doxy if they're really flared. Sometimes the Doxy is continuous, and sometimes I use it in courses. If they're not severe enough to need it normally, but they like went to the beach and had a bunch of alcohol and they're having a flare, I'll give them a course of it to kind of, again, calm it down. But it's very common.
And the mites, they can never be permanently eradicated.
No, it's crazy to think that we just have mites on our face all the time. It's disturbing.
Yeah,
it's disturbing to be honest, but that's why I'm just really aggressive with it. And I don't like to tell people that because they get so grossed out that they go crazy washing their face. And they wash off the first layer of their skin, which just inflames their rosacea. And it tends to be just this battle. But yes, that is one of the causes of it. And so that's why some people will be like, why are you giving me ivermectin? I don't have scabies, And yes, we do use ivermectin for systemic scabies, but in a topical form, it is used for these mites as well. So
cool. I think that's pretty comprehensive on rosacea. Next one I just want to cover is just eczema for the atopic people. Is it always going to be like allergy mediated? Is there anything else to do, or is it just predominantly antihistamines and steroids?
For eczema is difficult because it too is a lifelong commitment. When you have eczema, whether your eczema is flared or not, your skin barrier looks different. So if we took a punch biopsy of eczema skin and non-eczema skin, the difference is going to be of what it looks like. Eczema skin looks like a sponge. It literally has these holes in it. So their barrier is compromised. So things get in and things get out. Healthy skin is solid, like a fortress. Nothing gets in. That's the purpose of our skin. So you're constantly compromised with what goes in and what comes out. So when you have eczema, whether you have a flare or not, part of I would say 90% of how to manage eczema is going to be on lifestyle changes of preventing it from flaring. And that's going to be predominantly things like avoiding fragrances. So everything from the detergent you use, free and clear detergents that don't have the dyes, the chemicals, the preservatives is going to be big. The lotion you use, no fragrance or perfumes, things that are hypoallergenic. When you use something that's fragrance-free, it actually still has fragrance. So it has to say hypoallergenic. And then your soap, your lotion, anything that touches your skin is going to need to not have those things that can flare it. So that's part of the lifestyle. The other thing is avoiding things like a really hot shower, which while feels great for our muscles, so people think that it is good for your skin, it's actually really bad for your skin, especially if you have eczema. It sucks all the moisture out of your skin because your skin, again, looks like a sponge. It can't hold in your moisture. When you take a hot shower, all that moisture gets pulled out. So avoiding hot showers or lukewarm or just shorter hot showers, and moisturizing. You have to lubricate and almost occlude your skin at some point. Really, really liberal moisturizing. When you get out of the shower, it's a good practice to kind of pat dry where you're still kind of damp almost from the shower, and really head to toe moisturizer with something that's beneficial for eczema. So things that have ceramides in it. Ceramides are the building block to help moisture and to help repair your skin barrier. Eucerin eczema can be helpful. Sometimes CeraVe can be helpful. Vaseline, Vanicream. There are brands out there that are pro eczema, and the purpose of those is to help repair your skin barrier and to not have the other things that worsen your eczema. So a lot of lotions have alcohol in them. Why? I don't know the purpose of them, but if somebody with eczema uses a lotion that they just kind of picked up and they didn't realize that it had fragrance and had alcohol in it, they're going to think they're doing themselves a service, and it's really going to be worsening their skin, which could flare their eczema. So La Roche-Posay actually is a really clean line that has good moisturizers, really thick repairing. Again, the Eucerin eczema line I really like, but avoiding toxins, avoiding things that are going to be really flaring, minimizing exposure to certain materials and certain things, and then really, really moisturizing, I feel like are big preventions. That needs to be done whether you have a flare or not. When and if you have a flare, the approach is going to be based on where it's located. A lot of the times it's hands, elbows, knees, those thicker areas. And yes, steroids is going to be kind of their go-to for that. And it's kind of like asthma treatment almost, where you do something as a steroid as needed. And if you're having to use your steroid constantly, you then up the game to, okay, now you need something to use every day as prevention of this. And then your steroid still if you're flaring. So there are other classes of medications that can be really helpful for eczema. Eucrisa is a great non-steroidal prevention. So that would be an example of your maintenance. So let's say they get it on the inside of their elbows every single day. They're using their steroid, more than half of the month. I would then say, okay, and we don't want to use a steroid that long. One, especially in a thin area like that, you can get atrophy, you can get resistance. If they're dark skinned, you can get hypopigmented skin there. So then we would say, okay, it's time to up your treatment. We're going to add Eucrisa. You're going to do this twice a day in the areas you typically get it, in hopes that doing that will prevent the eczema all around. But
how does that one work?
It's a PDE inhibitor, so it works on the cell that actually, an anti-inflammatory cell, essentially. So it helps to keep you from flaring. So it works as a maintenance. And it is one of the standout medications to me. It's a little bit newer because it's safe for head to toe for kids and adults. And there's not a lot of stuff that's safe for kids these days. So this is the one that they kind of advertise from nose to toes, where you can put it on eyelids. If somebody has a rash on their eyelids, you're not supposed to put a steroid over the orbital eye because it can cause cataracts. So this one I like because you can use it everywhere, even for little kids that have acne or that have eczema. So that would be, okay, let's step this up. And then if you're still getting flares, you use your steroid a couple times a day while that's flared. Hopefully that goes back down, and then you stick with your Eucrisa. It's largely going to be based on prevention. You're always going to have a flare if you're using horrible detergent, you never moisturize, and you're scratching constantly. You're going to be flared. So education on the lifestyle thing is 90% of the treatment, especially if they're kids. It's really hard to get a 6-year-old to not scratch if something is really itchy, especially if it's already inflamed. The scratching is like fuel on the fire. It really does just completely disrupt the barrier, and it's difficult to manage. So that's where we come to like barriers, where you get those thicker ointments. So when it comes to moisturizing, you have really thin, like lotion. Then you have thicker, like cream, white cream. And then you have occlusive, which is going to be like ointments, clear and greasy. Those are the ones that are going to be literally occlusive. So you could put your steroid cream on and then put a thick layer of that on top of it, and it like sucks it down. It vacuum seals it, and then it amplifies the effect of the medication. So typically if I have, a 6-year-old who won't stop itching, sometimes I'll have them take a lukewarm bath to kind of soften the rash, put on their prescription medication, put on a good layer of an occlusion like Vaseline or Aquaphor, and then put on long pajamas. It's literally just kind of covered, protected, and occlusive. Bleach baths are kind of old school, but that is something that can also be effective in helping kind of reduce the bacteria. Obviously, you get into this cycle with scratching. Scratching is a big part of eczema. Our nails are gross, it itches, it's just natural to scratch. And then you have a secondary infection on top of underlying eczema. And that is really common, especially in kids, to have an impetigo or something like that because of all the scratching. And then it looks really bad and the parents are really concerned. This happens in adults too, but then it's again where you kind of have to really focus on the education behind the lifestyle changes, appropriate use of the meds, and the things to avoid that make it worse. Eczema is going to be really big. There is not always an allergy component to eczema, but they're always going to be a little bit more susceptible. There's something called the triad, and both of our kids have this, where, they have eczema, they have environmental allergies, and they have asthma. And it's typically the same reaction on a biological level that causes all three of those. And so if you've got one or two, you typically have all three. And so those kids are just more prone to environmental allergies. And so then they have the eczema and the environmental allergies, and then the environmental allergies kind of just set their eczema off. You don't have to have asthma and environmental allergies just to have eczema, but a lot of the time people have all three. And it's just difficult because when one flares, they all kind of flare. And so you just kind of have to be really on top of being proactive. Our son takes a bath every other day, and we have to make sure that he is head to toe covered in lotion. And if he's not, he's going to scratch and itch and it's going to flare. And there is also, so that's one of the factors. There are a couple different factors in the eczema realm. Eczema is kind of this umbrella, and atopic dermatitis, which is what eczema is one of the diagnoses underneath that. But then you have, 4 or 5 other things that are very, very, very closely linked, but not the same thing. Keratosis pilaris, which is that like chicken skin when they get, I think both of our kids have this also, when they get those little tiny bumps on their arms, that is also a variation of eczema. Seborrheic dermatitis, which is essentially dandruff, mostly on the scalp. A lot of the time in beard for men, it can be around your nose or your eyebrows, back of the ear, where your ears, where the area is red and flaky.
Treated with not steroids.
And it's typically not treated with steroids alone. A lot of the time it's a combination. Steroids typically are used to help treat the itching associated with it, but it's usually always coupled with an antifungal because it is predominantly fungal yeast sebum. Those are all closely linked. So sebum, again, just like rosacea, can be a trigger for those. And so anti-dandruff shampoos or antifungal medications like ketoconazole, those really work on lessening or lowering that. And then steroids are typically given just as a treatment for the itching in addition. I don't use steroids alone, which is a misconception. A lot of people do that because that just treats the symptom. It doesn't treat what's actually causing it, which is yeast or fungus and sebum. So like scalp's the most common, to be honest. I will use a ketoconazole shampoo that they use almost like a pre-treatment. So it's called a shampoo. It does not work at all to actually clean your hair. It is used as a scalp treatment. So I have them put it on before they get in the shower, and they really just use it on their scalp. They massage it in really well, and they let it sit for 10 minutes. So go watch TV, then get in the shower, rinse it out, use a dandruff shampoo. That is going to help reduce the overall scalp fungus. And then if they're also having a lot of itching, I'll give them something like Lidex solution, which is a mid-potency steroid, or clobetasol, which is a high-potency steroid, in a liquid form because liquid's easier to put on a hair-bearing area. And that will help with the itching associated with it. Sometimes it can be pretty severe, but I never just give them a steroid because that sometimes can make yeast or fungal infections worse, although it's temporarily helping the symptom that they have. So they think it's working. But that's typically my approach. A lot of the time, facial hair for men, eyebrows, and even chest hair, I'll use creams. Again, you can use liquids in hair-bearing areas, but on the face, you want to typically use creams. So hydrocortisone cream and ketoconazole cream. They can mix like a pea size of each in their hand, mix it together, and they can put it on their eyebrows, behind their ears, or even on the beard area. And that way they're getting the antifungal and the steroid treatment. And unfortunately, this is something that's lifelong too. So there is no, okay, you've treated it. It's sort of, a continuous thing. And there are triggers to that as well. So like cold weather can be a big trigger. Sometimes fragrance and perfume. So if you use a store-bought shampoo that's got tons of fragrance in it and you have seborrheic dermatitis on your scalp, it's likely to flare because of all of that fragrance and perfume. So that is why dandruff shampoos historically, Head and Shoulders and Selsun Blue, they don't have lots of fragrance in them because those tend to kind of trigger that. But I use those a lot. The over-the-counter shampoos, just on a regular basis, typically maintain it. So if you're using that regularly, you don't typically know that it's there because it's under control or it's maintained. So those are some of the big things under eczema. And if you have one, honestly, you're more exposed to having all of them. Your skin is just going to be more sensitive. And these people kind of know that things are more sensitive because they've trialed and errored a lot of different products, and it may burn or sting or worsen their rashes. So it is very much a lifelong journey. But once they kind of figure out the things that work for them, most of the time it's under control. One of the other things is because their immune system, it is not considered an autoimmune disorder like psoriasis, but it can be affected by your immune system. So let's say you have a viral infection and you're sick and you're on antibiotics. Your eczema is likely to flare because your immune system is somewhat distracted on what's happening. So just educating them of, when you travel and you don't have exposure control over, the hotel sheets and the hotel towels, you might get a flare. So making sure you bring your medication. If you're sick, you might get a flare because your immune system, so that's kind of a big part of it as well. It's very much predominantly lifestyle. Then you go into psoriasis, which is autoimmune. This is more systemic. So eczema typically does not have systemic involvement. Psoriasis, another inflammatory, lifelong chronic condition, is immune mediated, meaning your immune system attacking your skin, essentially causing typically anywhere between tiny pinpoint silver red patches or large plaques, can be literally head to toe. This is immune mediated. So treatment for this is going to be more systemic. Topical steroids are typically a go-to if it's mild. If you have one or two patches, if you have, large surface area, and then you also have systemic involvement like joint pain, you can have psoriasis that worsens into psoriatic arthritis, where that same immune system is now attacking your joints, and it can cause severe joint destruction. This is typically treated with steroids as a beginning, but typically increased to higher if that's not working and the disease is systemic and severe enough, to biologics, things like Skyrizi and Tremfya that are going to work specifically on immunomodulators that are going to help control that by controlling the immune system's attack on it, essentially.
Can this happen like first onset in adulthood, or is this something that they are probably an atopic kid growing up and now this is...
They're probably misdiagnosed as an atopic kid, but it was really psoriasis. And you can have, this is where it can be kind of tricky, is you can have psoriatic arthritis without having any skin manifestation at all. And this is the people that are like, my joints just hurt. They're swollen, they're achy, and it typically happens earlier in life. It's typically 30s or 40s, but in the last couple of years, I have found 70 and 80-year-olds with first onset psoriasis.
How do you diagnose the psoriatic arthritis without a...
So that is going to be where we use rheumatology. So there's a lot of skin diseases like lupus and pemphigus and psoriasis where we are very much a team with the rheumatology department. They can do blood work and imaging. So they would essentially do ultrasounds, x-rays of the joints, and they can do rheumatoid factors, things like that, where they can diagnose, yes, you have arthritis, but is this rheumatoid arthritis, or is this psoriatic arthritis, or is this just regular osteoarthritis? When we see our psoriasis patients, we're always asking them, do you have joint pain? Because it is somewhat of a guiding factor. You can have psoriasis, just skin, and not have any joint effects. But if you come to me with psoriasis and say, I'm really having joint pain now, then in my mind, we're not managing this well, and it's progressing, it's worsening. You should never have somebody who's on a biologic for psoriasis who has active joint pain. That means that it's not working well enough and the disease itself is not managed. And so we would refer to rheumatology for their workup side of things, their imaging. They typically would come back to us and say, yes, this is psoriasis involvement. And sometimes they manage the medications. So it just kind of depends on the severity, but a lot of the times it's back and forth. We usually have our patients as surveillance, whether they have joint pain or not, see a rheumatologist yearly, just as surveillance to make sure that there is no joint involvement, because it can destroy the joints where you need joint replacements if it's not being managed well. So systemic symptoms like that are always in our mind with psoriasis specifically, because eczema, while lifelong and can be annoying, it typically doesn't involve much systemically. Psoriasis, on the other hand, can affect a lot of different stuff. So that one is a little bit more aggressive, and it can even be harder to treat. The plaques can be very thick. You can have them on your hands and your feet, which is the thickest skin on your body. It's very hard to penetrate with the topical medication with that skin. You have to have very high potency, and it typically has to be an ointment, which is going to absorb a little bit better. But yeah, we typically manage that as a partnership with rheumatology.
I think melasma will maybe be a good transition into from, medical to maybe touch on some aesthetic subjects. Maybe that'll be a good middle ground. What is melasma? And, is it anytime acute anything? Is it mainly just a chronic? What am I going to do to treat or offer any improvements with it?
Yeah. So melasma is typically it's going to come to you as somebody complaining about pigment. And a lot of the times it happens after pregnancy. Hormones, birth control, pregnancy, those are big events that happen that can make profound melasma bad enough to where somebody's like, looks like I'm wearing a mask. And it can literally be sparing their eyes, but like a mask that they put on. And it can be that severe. But melasma on a simpler level is the melanocytes that are not where they're supposed to be, and they're responding to things that may happen. So obviously hormones can be one, trauma can be one. Let's say there's a burn, or let's say heat, let's say they got a sunburn. Lasers can cause, it's typically a post-inflammatory hyperpigmentation. So after inflammation, the melanocytes respond and create this darkening. So again, you can have that after acne scarring, where you can have pinpoint hyperpigmentation. Melasma is a little bit more widespread with hormones, but you can have it after a bunch of different stuff. But approaching it is another thing that is not a quick fix. Like many things in dermatology, it is going to be a continuous treatment, because melasma is, I kind of explain it to my patients like a layered cake. If you had many layers of the cake, and there's icing in between those layers, we're going to start treating the melasma from the outside. But as your skin always does, it's constantly creating new skin. The layer we see now is going to be different than the layer that we see a month from now. And there's going to be a different amount of pigment in each of those layers. So even when we treat aggressively, their melasma is going to fluctuate due to the layer that's present at the time. So it can be very confusing of why it may look worse next month or 3 months from now, even though they're following all the instructions. So that is where education is going to be really big with explaining the treatment process and expectation, because it's not just going to progressively get better and they're going to be cured. It's going to be a lifelong process. So big thing with them is going to be avoiding the sun, because the sun is only going to make it worse. It's going to make those melanocytes worse, come to the surface, go to areas they're not supposed to be in. Heat. So somebody who is a personal trainer who is constantly temperature hot, or then maybe sits in a sauna, is going to be drastically predisposed. So treating that person is going to be difficult because they're constantly in the state of a trigger. So avoiding saunas, avoiding heat, avoiding traumatic things like waxing and lasers at times, and the darker skin tones that have more, like obviously I have less melanin than somebody that might be Spanish. They're going to have a little bit more melanin in their skin, so they're higher risk for melasma. So educating the different skin tones based on that is going to be a big thing. So there's a couple different options, and it can be a little bit, sometimes hydroquinone is a great medication that is what people know of as a bleaching medication. This medication works by somewhat pulling out the pigment, but it doesn't necessarily prevent. So it's something we use in short courses. So we would use anywhere between a 4% to an 8% hydroquinone every day for about 3 months. You don't want to use hydroquinone for extended periods of time because it can confuse your melanocytes so much to where your face can get this blue hue where it literally looks like they have a blue mask on. And we don't want that. That's a side effect of using it too long. So I typically use it in short spurts where I use compounded meds for this as well. Hydroquinone is definitely one of the ones that are going to be in it. And then you're going to have other things like, again, azelaic acid can be really great. Sunscreen is going to be huge. Again, tretinoin or retinoids, which is going to, again, increase that cell turnover, make them peel at the beginning. It's going to shed that pigment even faster. So that can be another great one. Things that are going to be brightening, like vitamin C, can brighten the skin, work on pigment. I typically that's typically in the compounded medication that I use as well. Yeah, so this is an example. So this same pharmacy's compound that they kind of put together is a steroid because the pigment responds to inflammation. So at the same time, they're minimizing that inflammation, they're treating the pigment that's there, and then they're preventing from further pigment issues, all in one cream, in one compounded cream. So instead of giving somebody 5 different medications and making this really long skincare routine, I typically put a lot of these ingredients in one. So this one is triamcinolone, which is a gentle steroid. It's hydroquinone of 4%, which is the bleaching medication, and it's tretinoin 0.5%. So that's an example of one of the melasma medications. And then you can go into tranexamic acid, niacinamide. Niacinamide is a great antioxidant for the skin because it protects and restores almost. Niacinamide is great to put on for any and everyone with acne. It's somebody that's trying to be proactive about their skin barrier. But you can just overdo it with hydroquinone. So you have to make sure that you're taking breaks, I think is the easiest way of doing it. Bleaching and blending is kind of how they talk about it when it comes to treating it. You want to be able to pull out the pigment, but also blend the pigment that's there. And a big misconception is that people typically have splotches, unless they have that mask like I told you about. It's typically splotchy. And so people think that they should just put the bleaching medication on the darker spots. But then you just turn those spots a different color, whereas the rest of your skin is a different color as well. So you end up going from having dark spots to light spots. So when it comes to treating melasma, I typically treat the entire face. We're going to bleach and then we're blending so that it's all supposed to be one color. But it is a long-term process, and they get frustrated because they don't understand why it's worsening. And it's not necessarily that it's worsening, it's just that there was more pigment stored in this layer of the skin. So it can be really complex. Other things like microneedling, chemical peels, lasers, although lasers can sometimes worsen it. If done correctly and healed correctly, lasers can be really beneficial. Anything that's going to give them that peeling and reproductive process of the skin is going to amplify their benefits. So chemical peels can be really great. Obviously, you have to be already pre-treating on those retinoids that we talked about, but a chemical peel is going to give you a much deeper peeling, and if done the right way, it can be very beneficial. Darker skin tones have to be very careful because anything that causes peeling can worsen pigment if not done the right way and not healed the right way. If you get a chemical peel and you don't take care of it the right way, it's going to hyperpigment and it's going to look worse, and that's counterproductive. They just have to really be pre-treating, really be protecting from the sun. I almost tell them, if you're not going to avoid the triggers, do not waste your money, because it's a continuous process that you're going to be very frustrated with if you aren't avoiding what's causing this. And so I have to have that conversation before I even start treatment, because it can be frustrating. And then they're looking at me kind of like, why am I stagnant, or why am I not seeing results? And I'm like, you work outside and you don't wear a hat and you don't wear sunscreen. So you can almost, you kind of have to be direct with them on it. And so when you sunscreen is almost not even enough. If you work outside and you're treating melasma, you should have a hat and sunglasses and be, avoiding the sun as best you can. Working outside obviously is harder, but it's a difficult process. But I think that that's kind of the best approach, is a compounded medication, troubleshooting or alternating hydroquinone and not hydroquinone. For example, this one has the hydroquinone in it. You would give him that for 3 months, and then the following 3 months, you would just take that one out, and it would just be the other two. And then the following 3 months, you would have them put that back in. So that's why I like the compounding, because you can kind of pick and choose. But again, we carry the ZO line, and they have a whole protocol on how to treat melasma. And it is, it's a commitment. You're not treating melasma with using something inconsistently here and there.
What about pregnancy? Does it go away at the end of pregnancy?
No. Yeah, it's really difficult. If you're predisposed to it, it can lighten a little bit after pregnancy, but the unfortunate part about it is that it can be just lifelong. And if you have multiple pregnancies, then it kind of compiles. But once they're not pregnant anymore, treating it aggressively and being really proactive on it is how I would approach it. Not all of these things you can be on when you're pregnant. The good thing about ZO is they have something called Bright Alive, which you can be on while you're pregnant, and that works on pigment, and it's a little bit more gentle, but it works on brightening and on pigment. That is something you can be on. You can also be on things like azelaic acid. You can be on vitamin C. You can be on sunscreen. At bare minimum, you can be preventing with sunscreen. No, it's not going to do anything for the hormonal side of things, but the sun we don't realize how much sun we get. When you get in your car and you drive to work and you're in the car from 5 to 10 minutes, you're getting sun. Whether you think it or not, you're getting direct or indirect sun. Walking from your car, walking to your house, you can have anywhere between 10 minutes to hours of sun a day. And if you add that up in a week, add that up in a month or a year, you get a lot more sun than you may intend. Just daily sunscreen is really big for preventing melasma.
From the aesthetic and cosmetic side of dermatology and everything, how do you view, say a 20-year-old who's, I want to keep this face forever, compared to somebody who's 40 and is just now starting, has some signs of aging, to somebody who's 60 and is trying to undo some stuff? Or maybe they've been perfect until they're 60. Do we keep anything going? And then also, do guys do any type of anti-aging things?
So aging, in a sense, in my opinion of aging, I typically am referring to the changes that are happening in the skin. So starting in your mid-20s, your skin is starting to decrease the production of collagen, elastin, hyaluronic acid. And these are the components of our skin that keep our skin tight, firm, and bouncy. And so you start decreasing in production in mid-20s. By the time you're 40, you have a massive lack of those things. And so protecting from further breakdown. And then you have things like genetics, free radicals like the sun, and smoking and alcohol and poor diet. All of those things that break down our DNA are only worsening the natural decrease in production. So in a sense, when we talk about anti-aging, I think it's multifaceted, but I think part of that is going to be avoiding those free radicals. Again, sunscreen is huge. The sun literally changes our DNA, and it is not always an instant onset. So you get sun in your 20s, you may not see the negative effects of it till you're 40 or 50, but protecting from it is still important. Avoiding smoking and alcohol, eating a well-balanced diet, exercising, all of those things that keep you healthier and protect from the free radicals are going to be considered anti-aging. Things like glutathione, things that are helping you protect from free radicals. So that's anti-aging. When it comes to the skin, it's important because we want to protect from what's breaking down our skin. We're already breaking down naturally, then you add all the extra. So things that are going to be protective are going to be antioxidants, niacinamide, like we talked about. Vitamin C is also another antioxidant. Those things are going to be really important. The sun protection is big. Vitamin E, resveratrol, those things can be in skincare. They can also be taken as supplements to kind of protect from the breakdown of free radicals. So then you have how do we rebuild our collagen? How do you rebuild the elastin? And that is kind of a long answer, but on a simple term, things that can regenerate. Again, vitamin C can regenerate collagen. So if you have skincare products, vitamin C should be in there. Retinols, again, tretinoin and adapalene, that can because it's increasing your cell turnover, it's stimulating collagen. And that's why it works well as an anti-aging, because it's helping to firm, tighten, and plump your skin again. Hyaluronic acid, again, just supplementing with that. Niacinamide, collagen supplement, like we said, bone broths. AHAs and BHAs is a category of acids that are in a lot of stuff. A lot of our ZO stuff has it. Those acids help to chemically exfoliate, and in that process boosts collagen and elastin. So having those ingredients sprinkled throughout your skincare routine or even as supplements can be really helpful. Again, a lot of our ZO stuff has that stuff in there. On a more complex, aggressive level, I would say chemical peels, things that are what we would call regenerative. Chemical peels, microneedling, lasers. Those are going to be procedural type things that break down your skin as micro injuries. And then in the reparative process, our skin massively produces hyaluronic acid, collagen, and elastin. So that wouldn't be something you do daily, but having your daily skincare routine have them in them, and then doing a regenerative procedure, a couple times a year would be great. Chemical peel, 3 chemical peels a year, Dr. Obagi from the ZO line says stops your aging in progress. So 3 chemical peels a year, microneedling, you can get them as often as monthly, but those are going to be aggressive ways of building up and producing that collagen and elastin. So that's going to be really big. The process starts in the mid-20s, but then it continues to, you lose 1% of your fat, which, in your face, we don't want fat in certain areas, but for youthful appearance, you want fat. So this is a great example of in your 30s and 40s, how your face fat pads distribute. And over the 10 years generation, the fat pads literally shrink and start moving down. So when you're, 50s and 60s, you've lost 60% of those fat pads. So these ingredients and these procedures help to replenish that. Then you have Botox and fillers. A filler is a hyaluronic acid gel, and strategically placed in an area where there is much less fat pads can help plump up to make that simulate what it looked like when you were 30s and 40s. That's a little bit of that's not helping you produce your own, but that's replacing what you've lost. So that can be used to help rebalance your face when you've started to show signs of aging. And that's just going to be, based on the person. But there are even biostimulator injections like Sculptra, where you can inject areas of fat loss that helps you produce your own collagen, elastin, and hyaluronic acid over months to years as a continuous process. So those injectables are going to be great for helping you produce your own as an anti-aging. And so I kind of say it's never too late to start. I've very recently, in the last couple of years, my cosmetic practice was mainly focused on 70 and 80-year-olds. And they're like, I've never done this, and I'm like, it's never too late to start, because it's going to depend on how much you want to spend and how aggressive you want to be. You can, again, get these procedures once a month and you're going to have results. Are you going to look like you're 20? No. I don't know that there's an actual way of stopping all aging. And that's not necessarily the goal. To me, the goal is to look age appropriate, but to look youthful and refreshed. We want to look appropriate. We don't want to look fake, but we want to be healthy. I think that's a big balance for me. And that's why I think even in men, at bare minimum, sunscreen can be pivotal in just slowing your aging process. But men are a little bit difficult to get them to comply to a skincare routine. So I think procedures is almost easier for them. Getting something 3 to 4 times a year is easier to get my husband to do than to get him to put sunscreen on every day. But yes, I think men in cosmetics, it's more common than you think, to be honest. Botox and fillers, I think Botox is big for them because Botox is preventative. So Botox is going to prevent those really strong muscles from moving, to prevent the lines from sinking in. But there's this stigma, in men's world that it's, feminine and it's not necessary. But I think if done the right way, you shouldn't really know. No one should know that you're getting cosmetics if it's done the right way. But I think skincare and sunscreen at a minimum, it takes 2 seconds to brush your teeth and put your deodorant on. It takes 2 more seconds to put your sunscreen on. So I think at bare minimum, stimulating or regenerative products would be simple for men, but I think it just depends on the person. But yeah, there's going to be a wide variety that's all going to be based on your comfort level, your commitment to this, and how much you want to spend. It's going to be dependent on the person, basically.
And sunscreen's not going to fix anything really in, even months, but it's preventing 10, 20 years down the road.
And LTMD, which is the sunscreen we use and that I use personally, it actually is going to be assisting in a couple different things. It has lactic acid, which helps with texture, fine lines, redness. So it's going to help acne. It's going to help rosacea. It also has niacinamide in it, which is an antioxidant. So it's going to protect. So just using an LTMD sunscreen a day is not only protecting you, and with sunscreen and antioxidants, it can help the texture, tone, and color of your skin in just that one product, which I think is great for men.
The next will be just a skin check. What are you looking for in somebody comes, I want a comprehensive skin evaluation. What are we going to do? What are you looking for? And what are the next steps if you find anything?
One of the main things, I think the most common skin cancer that is out right now, or that is prevalent right now, is a basal cell. And these look, honestly, when I find them, it's somebody that says, I have this pimple or I have this bug bite. It's been there for 4 months. And to me, that's an initial red flag because a pimple or bug bite are typically not there for that quantity of time, but they look like a red bump. They're raised typically, just shiny, kind of unassuming, or they can be raised flat and kind of look like a little burn. And it doesn't really have symptoms. Sometimes it may bleed or kind of slough off, but they're typically unassuming. And I typically will tell people if a pimple or a bug bite is there for a longer period of time, it then is concerning. It is very common to be on sun exposed areas. So what's showing right now, your arms, your neck, your face, your ears, your scalp, that is where most basal cells are, especially in men, are very commonly on the face. So getting skin checks, I think, is just the easiest way to know, but doing a monthly self-skin exam. So you're naked in your bathroom, you just get out of the shower, you're looking at all of your skin. Is anything new? Is anything growing? Is anything hurt, or is it changing color, shape, size? Those are big things. But getting a skin check once a year by somebody who knows what they're doing is ideal. But that is the most common. Is it going to be a basal cell? Second most common is going to be a squamous cell carcinoma. These are typically pink and scaly. So they look like a scaly red bump that probably looks like a bug bite, but it's kind of scabbed over. It's a little bit more flaky almost. And so these people will come in and say, oh, I have this wart. It won't go away. It's itchy and it's growing. And it typically looks, again, like a red scaly bump, and it is very commonly, again, in sun exposed areas. The big kicker is it's not going away and it's growing. So that's always something to keep an eye on. Obviously, the most concerning, not the most common, most concerning would be melanomas. And these can honestly today look like anything. They can be red, they can be black. The ABCDEs, we're looking at asymmetry, we're looking at the borders, we're looking, is it changing? Is it evolving? Is it large? Does it just, when you look at your arm, is there a freckle that just, boom, stands out at you? That is a very kind of telltale sign of something to kind of get in and have somebody look at. Aside from that, you're going to be looking at what we call dysplastic moles, which are atypical freckles. They're not quite cancers, but they have a concerning pattern. That can look like any freckle or mole that is going to be hard to find. But the big thing is noticing on yourself. If I see you once for a skin check, I can't tell you that this freckle has changed because I'm seeing you once at one time, one moment in time. You see you more than I see you. So if you look at that same freckle on your arm every single day, you would be able to tell me that it has changed. So I usually have people take pictures. I saw somebody yesterday who had a birthmark, and birthmarks, although you were typically born with them, have lots of melanin in them that make them really dark, and they can even turn into cancers. So I always have people take pictures of their birthmarks because they're not out of the woods. They can, and the more sun they get, the more that DNA can change, the more likely they are to turn into cancers. So I typically have them take pictures, keep them covered in sunscreen, and constantly monitor them. Have somebody take a good picture and have them hold the phone next to it and look and compare once a month. Okay, this picture was, 5 months ago. This is how it looks now. It looks completely different. It needs to be checked out. So sunscreen is going to be big, but the basal cell, squamous cell, melanomas, dysplastic moles, those are the most common. And I would say if you've got concerns or questions, get a skin check. A simple biopsy can confirm most things, where we do quick numbing, we shave off a tiny piece of it, we send it to the lab, we get an answer within a couple of days. Based on that result would be based on treatment. A lot of the things are very simple treatment. Most skin cancers, are shallow and slow growing. You can have deadly, more concerning ones that invade, although very rare. But protecting from the sun and getting skin checks regularly and kind of just monitoring, being self-aware of your own skin is probably the best practice that I can advise.
And the melanomas and cancers, they can happen even in not sun-exposed areas.
Yes.
Right?
So melanoma specifically does not necessarily have to be in a sun-exposed areas. They are commonly, but sometimes it's on your back or your scalp or your toe. Bob Marley died of melanoma on his toe because he thought it was just a bruise because he was a soccer player. So toes, feet, hands are big. Backs, scalps, literally everywhere. You can have it in your eye. So when you go to the eye doctor, they typically dilate your pupils and look at the back of your eye. And melanoma is the one that can spread quick and quiet. So if you have a history of it, or if you have a family history of melanoma, you're automatically at higher risk. So getting skin checks yearly would be key.
This is kind of even off topic, but I've had a pharmacist kind of balk at me in the past because I prescribed an antifungal, an antibiotic, and a steroid. And he was like, "Hey, what are you trying to treat here?" And I was like, I don't know.
Yeah.
And then of course there's a derm referral at the base of that, at the end of that.
Yeah.
But when you get that from, an urgent care, primary care, emergency department, is it like, all right, we need to do some treatment to these guys? Or do you all, you've kind of said that you do combinations of stuff, just kind of feel.
So if there's an unknown where we really don't know what this origin is and we're just kind of throwing everything at it, hoping it responds to something and it's still there, I'm going to biopsy it. At this point, if it's not fitting in or responding to what looks typical, I would biopsy it to get a more molecular assessment, a pathophysiological analysis of what's really happening here. What are there fungal cells in this tissue? Is this more inflammatory? A good dermatopathologist can really assist. And so that's what I would do. If you referred that patient to me, I'd want to know, did it respond to any of this? Pictures are key. Do you have pictures of what this looked like before and how it looks now? It is really like a story in dermatology and the evolution of certain rashes. So pictures are always helpful. If you have something, take a picture of it so that you can show it to the provider of the evolution. But I would ask for pictures. I would do a very in-depth history, because a lot of rashes specifically sometimes are caused by a medication you took one time 6 months ago. Like, it can be a fixed drug eruption. It can be something very, very rare. So I do a huge history and physical on all of their prior medical history, their family history, medications, if there's any new supplements or medications. So a big, big history. Have they traveled recently? Are there new animals? Have they gone anywhere? Have they stayed anywhere? And a lot of the time they're looking at me like, how in the world is this relevant at all? And when it comes to rashes, it's all relevant, because there's not a one size fits all when it comes to rashes. Hopefully it's something like psoriasis and it's simple, but most of them are not that simple. So I would get a huge in-depth history, and I would get biopsies.
Do you do any adjustment to skincare routines now that it's winter, or does that change with the seasons at all?
A lot of people, I'm from Florida, so I am not used to seasons at all. That sounds weird, but it's typically the same season year round. So I don't typically tweak anything because that is what I'm used to. Here, people are like, oh, this is the season for your chemical peel. This is the season for your more invasive procedures like your lasers, because in theory, it should be less sunny. So you're less likely to have that pigment. And so this is where people want to do those more aggressive treatments to minimize their treatment. In my opinion, whether it's winter or summer, if you're protecting your skin with sunscreen and the appropriate care, if you get a chemical peel, you don't want to go to the beach the next day. You want to kind of stay home. So your aftercare is typically geared towards minimizing those after effects. If you're doing those things appropriately, I don't see why you have to wait to do them during winter. But here, that's more so what people are saying is this is the time to get back on your retinoid and to do those procedures. And in my opinion, I just think do them year round, but just do your aftercare appropriately. Other than that, no, I would really say sometimes people are drier during these times because it's colder, there's a little bit more wind. And so that might require a little bit more hydration. But again, if you're using good products that are already protecting your skin and you're already using moisturizing and hydrating things, then your skin should be fine. But I would say sometimes people need a little extra moisture. But I do these things year round.
A lot of times we get people who will present with this giant, I feel 12-step skin routine that they're doing 1 to 3 times a day. How do you break that down, and what do you try, and how do you remove stuff and know that they're still trying to get what they want out of it?
Yeah. I think for me, it comes down to looking at the ingredients, because a lot of the times people are duplicating. They're using a cleanser, a moisturizer, and a wipe that has salicylic acid in it. And there's no need for that. So I would take out 2 of those. Salicylic acid as an ingredient is beneficial, but you don't need it in 3 different variations. You have it in 1. So whatever is your favorite. I personally like it in a wipe as a toner, but you can use it in a cleanser. You can use it as a moisturizer, but you don't need to duplicate. So I would look at that. 1, if things are old, if things are fragrancy, and if things are duplicated. So on a basic level, your skincare routine, again, it can be complex, but on a basic level, cleansing, toning, moisturizing, protecting. So we need a decent cleanser. It can be depending on your skin type, and this is why it would be different for everybody. Hydrating, exfoliating if you have acne, gentle, so your cleanser. Your toner, if you have acne, salicylic acid would be great. Glycolic acid would be great. If you're dry, you can have a witch hazel or a hydrating toner. Zeo has a calming toner. If you have redness, a toner. An SPF. At bare minimum, SPF needs to be in everyone's routine for the obvious reasons we've kind of talked about. But protecting from free radicals, protecting from triggering of rosacea and melasma, protecting. Moisturizing, again, is going to be a big thing, hydrating specifically, but we don't want things to be duplicated. On a much more complex level, when it comes to aging, if you want to introduce other things that are, again, vitamin C can be great for antioxidant for melasma. So it depends on how complex their routine is. That typically is so overwhelming to people that they don't do it because it's so much. So you kind of have to gauge what their goal is and what their level of commitment is. If I hand a guy a 12-step skincare routine, he's not going to do any of it. But if I hand him 1 sunscreen and 1 product at night that has 5 beneficial ingredients in it, he's probably more likely to comply with that. Then you have girls and women that want 12 steps and they think more is always better. In my opinion, it is not about the quantity of your steps. TikToks and Instagrams has dampened the societal pressure of needing to have a complex routine. But I feel like it's ingredient specific, not quantity specific. So if you've got the good beneficial ingredients, it does not need to be really complex. So it kind of depends on the person, but I kind of have to counteract what society and TikTok are putting out there that, you have to look like a glazed donut. Hailey Bieber says, if I look like a glazed donut when I go to bed, I'm going to have acne when I wake up. So it is not a one size fits all, but I would say it depends on what we're trying to target, their level of commitment, and meeting them where they're at.
Yeah. What do you look for in a sunscreen, and what needs to be the minimum effective dose for a sunscreen?
Yes. So sunscreens, depending on the day, again, I would say a minimum of 40 to 50 SPF daily. If you're going to be in the sun long periods of time, reapplying every 2 hours is key. Physical.
2 hours.
Yeah. which is where everyone gets stumped because everyone is, I put it on and then 8 hours later they're burnt and they don't understand why. You have to reapply, which is the hardest part in my opinion. Physical and chemical are the differences in skincare or SPF. So physical is going to be your zinc, your white, a little bit stickier. Most people hate it. LTMD has transparent zinc that does not cause acne, stickiness, or even that white film. Physical is going to be a better protector than chemical. Chemical is going to increase chances of redness, even burning. When it gets in your eyes, it's going to burn, and it sweats off decently. Physical typically does not as bad. So physical is where I would go to where it has zinc, but you've got to find the one that doesn't cause the white sort of sticky residue.